Dr. Lover, and again, thank you so much for Well Ahead and Echo for inviting me today. Um, Obviously, great to see Dr. Lover after a couple of years, I think at least. I'm so happy to see her not only just grow in her existing position that she's doing, but also such great education material to so many people. And I'm happy to be a part of it. And I'm definitely more than proud of her. So congratulations and thank you for this opportunity again. So again, I'm Gaddy. I'm Dr. Gaddy, whatever, Shilpa, probably the easiest considering there's two Gaddys on this. I'm a nephro-crit care physician, practice out of Alabama at present. I'll get right to the presentation just for the sake of timing. The next slide will tell us that essentially I have no financial disclosures or conflicts to be said. The next couple of slides, I just want to kind of illustrate the worldwide presentation of diabetes that we already are aware of, greater than 10% of adult population, with a prediction that this will obviously increase over the next 10 years. A good bit of the patients, over 50% of the patients who currently are on dialysis are unfortunately suffering from diabetes as well as hypertension, in addition to other diseases as noticed in this pie chart here. Next slide. So diabetes is obviously rampant, and as I said to you, increasing throughout the entire world. And what can we do to prevent diabetic kidney disease, also known as diabetic nephropathy, which can obviously lead to chronic kidney disease and end-stage renal disease? The things that we have to think about is ultimately what sort of burden is our society going to be facing. Now, in terms of the incidence of it, as I mentioned to you, 50% of all new cases of end-stage renal disease is from diabetes. The cost alone in the US is well over $20 billion that gets spent in end-stage renal disease. Usually much higher in terms of patient year cost towards the patients that are diabetics versus that are non-diabetics. And obviously the mortality is much higher as well, as these patients unfortunately suffer from cardiovascular disease, which is the leading cause of mortality ultimately. There are about 5 stages that I mentioned here, and I don't necessarily have to break these down specifically, but everyone can read these and hopefully have access to this presentation at a later time. Ultimately, what is important here is that the different clinical features that we look at are albumin to creatinine ratio and sort of where that stands with regards to the timeline from the onset of diabetes to where it progresses. And what happens at each stage is obviously listed in the very first column of this particular slide here. Early on, you kind of see an increase in GFR sort of situation, and subsequently it leads to a decrease in GFR as you continue to go into advanced stages of kidney disease. Early stages of diabetic nephropathy is where you have your albumin to creatinine ratio that is less than 30 milligrams per gram of creatinine. And again, that increases as you continue to go into deeper stages of diabetic nephropathy. And on average, it takes about 10 to 15 years for you to kind of see that full-on effect with regards to where you are from a stage 5/end-stage renal disease nephropathy pattern, where unfortunately you will need either a transplant or a dialysis, depending on what's available to you. And this particular illustration here just kind of talks about sort of that same exact progression that I mentioned to you over time period. And what you see here is that median onset of when you see stage 1 to where you progress into stage 5 is, again, you're looking at about greater than 20 years. And ultimately what you look at are sort of the urinary protein concentration, what sort of systemic symptoms and manifestations you may get, in addition to what you notice if you were to ever have a kidney biopsy done, and what sort of morphology and histological findings you may be able to find in that particular group. Nothing really to bore you into the details of this. Again, hopefully you'll have access to the slide at a later time so you can go into the individual parts of what you see in stage 1 and stage 2. Same thing here, same exact illustration. What is important here is to know that the cardiovascular death obviously is present throughout the entire time, from the very beginning to where you progress into end-stage renal disease. Obviously, it's much higher when you're sort of in the stage 5 cases of diabetic nephropathy. Next slide. So what does ADA currently recommend? Screening for microalbuminuria. ADA recommends that you should screen these patients at the time of diagnosis and annually thereafter, so once a year thereafter. There are obviously different ways of sort of obtaining these numbers. The European guidelines essentially say that you should try to get a measurement of first AM sample of a urine collection. And it's usually a spot sample, and that's usually adequate for you to go ahead and try to arrive at this diagnosis of microalbuminuria. It is also recommended for type 1 diabetics to start the screening 5 years after the diagnosis, and again, yearly thereafter. So those are the couple of things that should be kept sort of in the backdrop of things for you to remember. A little quick presentation or illustration of sort of what you see in normal versus that in overt nephropathy. Again, at the beginning, top part of the slide will tell you sort of what you expect from a protein standpoint, what to look for, whether it's a dipstick analysis versus a spot collection, which is, again, the far right-hand corner of the table here. And then again, what you see normally, and then what you see in microalbuminuria, where again, the definition is going to be 30 to 300 milligrams per gram of creatinine noticeable. And then in overt nephropathy, where you see greater than 300 milligrams of albumin in a 24-hour sample that you can go ahead and obtain by getting a urine collection. Next slide. So what are the stages of preventing progressive nephropathy? So you have one, glycemic control. You also have to kind of worry about sort of the lipid lowering. We spoke about this earlier, quitting smoking as well as weight loss, and everybody had great ideas on that. Blood pressure control and the inhibition of the renal angiotensin system, or the RAS system. Glycemic control is sort of the first thing that we want to try to talk about here. And there have been, next slide, multiple studies that have been done historically. These are old studies, but what they looked at is sort of the aggressive and intensive control of A1C compared to that of a little bit more of a lax control. Aggressive control is sort of a less than 6% in terms of A1C versus that of 7. And what they noticed is that, and these are again old studies, and obviously newer studies will have to be done and randomized, controlled, et cetera, for us to be absolutely certain of this, but there have been no renal benefits of intensive or aggressive control of blood sugars in patients that are type 2 diabetics. In addition to having cardiovascular benefits, also not noticeably in those patients that have had intensive blood sugar control, again, in type 2 diabetics. Next slide will tell you that essentially the mortality actually increased in those patients. This is a UK-based study, but certainly an older study as well, but it also shows that the mortality increased for those patients that have had an A1C less than 7.5%, with the notion that that actually caused more hypoglycemia and other sort of effects that you get when you have an intense control. So what is the ultimate recommendation, next slide, for glycemic control? There's clear benefit that intensive blood sugar control in patients may obviously lead to some form of a macro or rather a microvascular improvement. However, sort of the effectiveness overall in terms of renal benefits and all that is unknown and would need to be reconfirmed with possibly some newer studies that are much needed. If there's any benefit of any of this, you need to go ahead and try to obviously get a better guideline to enforce patients. However, at this particular present time, ADA recommends A1C of less than 7%. Again, that's not going to be less than 6%, which is sort of what was done in some of these other studies. Stages of preventing progressive nephropathy. We spoke about all this. The next one is going to be the lipid lowering, is what we're going to talk about, which reduces the cardiovascular events in diabetics. And what you're noticing here is just a hazard ratio. Everything on the left side essentially tells us that not only the primary endpoints, but also the secondary endpoints of what happened in this study that was published in 2004 shows that it reduces cardiovascular events in patients who are diabetic. So essentially, that leads us to the next slide into what ADA recommends. 2021 guidelines say that most patients, and whether that's as young as 20 or as old as 75, could benefit in the right sort of setting with initiation of a statin therapy in addition to lifestyle modification. So I recommend that, again, you all just look at this particular slide in your own time. For the sake of time, again, I will not go through every single sentence here. The next stage, again, is going to be for you to go ahead and look at quitting smoking and weight loss. Again, y'all spoke about that earlier, so keep that in mind. Subsequently, blood pressure control is going to be important, and kind of keeping that at base to a recommendation based on guidelines is going to be important, and I'm not going to talk about that for the sake of time. The last topic is going to be the inhibition of renin-angiotensin system. And that leads us to sort of the next slide, where we have, again, old studies that essentially prove the addition of an ACE inhibitor and the progression to death or dialysis or transplant to be far less in patients, especially in type 1 diabetics. So definitely keep those group of drugs in mind, ACEs and ARBs, when you're going forward. And this next slide will sort of give us the same sort of information, but with regards to an ARB this time around. So earlier it was an ACE, and this is an ARB, and essentially, though these studies have been, not in this particular last decade, they're a little older, but it still shows that the progression of nephropathy, as well as overall incidence of progression to death or dialysis, is far less when you have an ACE or an ARB on board. So these next few slides are essentially questions that I've developed. Y'all can definitely go through these in your own time, and I'm hoping that y'all have access to these slides to actually do that. And I kind of want to end here, unless somebody wants me to go through these particular questions, and then kind of open the floor for questions if there are any.
Great, thank you so much. This was very informative, and I think one thing that caught my eye is this whole hyperfiltration stage. So we could go through this case later on. I would rather everybody ask questions. So that's my question at the end, but we'll let everybody else ask a few more questions.
Everything was crystal clear.
I think everybody is shy. And we know at ECHO, we're very comfortable sitting quietly, waiting for questions.
I have a question.
Okay.
Yes, sir.
What is your take on SGLT2 inhibitors and chronic kidney disease? When do you really think towards stopping them if the creatinine is worsening? At what point? What is your typical advice? If the creatinine does rise, do you immediately stop? What sort of input do you have in that regard?
I'm sorry, I didn't hear the first part of the question. You said with regards to what medicine?
SGLT2 inhibitors.
SGLT2 inhibitors.
And creatinine, when do you consider stopping them when the creatinine is rising? What do you do? Do you do anything differently? Do you reduce the dose? I just wanted your take on SGLT2 inhibitors and CKD.
So essentially, we kind of start them possibly at renal dosing to begin with, depending on which medicine that we're using, and sort of half dose it or not, again, depending on where their serum creatinine is and where their creatinine clearance is initially. Ultimately, these patients are not just on SGLT2, for example. Most of the diabetics also suffer from hypertension. And so you're also on ACEs and ARBs and a bunch of other medicines which could bump the creatinine as well. So it's not exactly a clear-cut picture of what's more of the insult that the kidneys are facing. Is it a combination of all those meds together, or is it to be blamed purely on SGLT2? I tend to usually decrease, if I see an obvious increase of serum creatinine after I have added a new medication, I tend to decrease the dosing before I completely get rid of that class of drugs altogether. But again, I also try to start one drug at a time so as not to confuse the picture as to which one caused what. I can't necessarily think of any specific situations where it was a clear-cut SGLT2 by itself causing such, because again, they're on multiple meds that could do the same exact thing. So, but yes, ultimately halving the dose, if not decreasing it in some form or fashion before we go ahead and completely take that off.
Thank you.
Sure.
Great. Any other questions? Okay, these guys are getting good at being comfortable sitting quietly also. We have to switch up our game. Okay, so I have a quick question. I actually have two. One is kind of practical advice on, protein intake. Of course, we tell our patients not to be on NSAIDs and hydrate well and so on. Can you give us a little advice on, if you're CKD 3 or 4 or wherever we should say, you know what, let's not have, burgers every day. We're going to decrease salt intake. Maybe we limit some meats or some protein, whatever their highest protein food is.
Sorry, you asked me like sort of nutritionally what to kind of.
Yeah. So at what point do you limit their protein intake, or how do you kind of do it if we don't know exactly milligrams or grams of protein and patient doesn't really know how to count? What is your advice when they're a little more advanced stages of kidney disease? Kind of how could we tell them to take less protein in, and when do we tell them this?
So essentially, again, nutritionally speaking, I will tell you just part of fellowship training has been that they didn't necessarily embark on that a lot, meaning, we've had great dietitians and nutritionists and other folks who kind of helped us with regards to having that one-to-one education with the patients. Specifically, with regards to what I've told my patients is that, as long as what matters to me more is sort of their salt intake, which could obviously lead to proteinuria as well. And so my goal is to go ahead and get them to kind of concentrate more so on products that are already fortified with a lot of salt that people don't necessarily know about. And, for example, they think bread has no salt, which is a false situation, false thought process. So a lot of the times we concentrate more on sort of the intake of salt, which could again lead to proteinuria as well, more so than specifically with regards to protein. Now, later on in stages of kidney disease, we don't necessarily think truly that having large amounts of protein can lead to, any form of kidney disease, but can certainly kind of, could that lead to proteinuria? Probably not. But again, we're talking about actually, in fact, replacing and supplementing protein and kind of giving them right sort of situation or right sort of content of daily intake of protein when they're on dialysis and things like that too. So, so we don't necessarily tell them to completely limit it altogether. However, at the same time, if you are essentially eating more protein as a result of decreasing your carbs as you are in diabetes and in diabetics, we do say that just kind of watch your intake altogether, but not necessarily limit it per se.
Okay, excellent. And I hear you say, involving nutritionists, and, so we traditionally think of, okay, let's send you to diabetes education. We don't necessarily think, hey, you have CKD, we should send you for that as well. So I want to just echo that, that, if somebody knows what to do for their diabetes and they say, I know exactly what I'm doing, I really don't need any teaching, I think we should probably say, you also have chronic kidney disease, they will teach you what to do for that. So just to get them in the door to kind of get their control better for everything, right? Just to get another pair of eyes on them and more advice. Okay, thank you for that. Anyone else, any questions?
Just a comment, Medicare covers RDs and CKD for patients that are, I believe it's stage 4. The ladies from FMOL may be able to attest to that, but so definitely just agreeing with you, Dr. Leverey. And if doctors are concerned about reimbursement, that area will be assisted to.
Great, so registered dietitian is covered at that stage. Excellent. Thank you, Christine. Okay, well, it's 1 o'clock, just a little after. I don't want to keep anyone. I just want to thank Dr. Gaddy again. Thank you so much. It was a wonderful presentation. We will have this on the website as well, so we could go back to those tables. Thank you, everyone, and we apologize again for the little beginning issues with connection with everyone. So